Hi, everybody. Welcome to our CCRN webinar. Let me make sure everything's, yeah, there we go. Sorry, I know I'm coming in a minute after the hour here. I was on another meeting and looked at the time and I was like, oh my goodness, we're starting right now. So rushed on over here, but I'm excited. We're going to do a quick 30-minute rapid 30. If you've been here before, you know the flow. We just go through some practice questions to be able to have an interactive approach to taking practice questions. Get out of that more mundane process and work through more live rationales and talking through the concepts together. So these are always really fun for me. Let me know who's here, who has been here before, when your test is scheduled, if you're scheduled for your CCRN, if it's your first time here, just some facts about where you're at in your CCRN journey today would be awesome. Um, Really quickly, while we do that, I'll talk briefly about the CCRN. Just in case there's anything that you don't know, the CCRN is a critical care registered nurse certification. So if you've got ICU experience, specifically 1,750 hours, which is about a year full time, you can take an exam to prove your critical care knowledge and become certified. And hopefully your hospital will pay you a little bit more money every hour to be certified, reimburse you for the cost of the exam, that sort of thing. If you're looking to go back to school, it's a really good idea to be certified in your specialty. So if you're working in critical care, that would be the CCRN. Here at Archer Review, we have a program out for the CCRN to help nurses prepare for this test because we are very passionate about people becoming certified. I know for me, it really increased my confidence at the bedside just going through the process of studying for this exam. So it's a really great thing to have. So we've got a 1,000 question Q bank, over 13 hours of on-demand video content. We do these free webinars typically every week or so. And now you can get contact hours for that course. If you complete 80% of the course, the CCRN course, then you'll get a contact hour certificate for 13.75 hours, which is super exciting. Okay, that's my like really quick spiel. Let's go ahead and get started. Try to throw your answers in the chat as we go through each of these practice questions. It helps me know what we're thinking the answer is, and that way I can spend a little bit more time explaining. If everyone's saying one answer and it's not the right answer, I can know that and explain it a little bit more fully. So let's go ahead and get started. Question one here. A patient with ARDS on pressure control ventilation becomes agitated and desaturates. Plateau pressures are elevated. What is the priority nursing intervention? What do we think? Got one answer in. I'll wait for a couple more responses. Nice. Seeing some names again. Welcome back. Yeah, we've got a couple different answers here, actually. I got myself tripped up there for a second. Okay, so the correct answer here is going to be B. Administer sedation and reassess. So this is an ARDS patient on pressure control ventilation, which is pretty typical for ARDS. And with pressure control, it's luckily it is a control mode. When we think about pressure modes, a lot of times the first one that comes to mind is pressure support. And if we've got somebody on pressure support, we're likely not going to want to sedate them further because we are concerned about them being able to control their own respiratory rate. And pressure support is not going to give them a rate, but pressure control will. So this is a way that if we're really concerned for that barotrauma, and even doing a low milliliters per kilogram volume control mode is not working well for our patient, we can put them on pressure control where every single breath, we're still controlling how many breaths per minute we give them, but it's an amount of pressure instead of an amount of volume. And that can be safer for an ARDS patient. It's not like every single time we have an ARDS patient, we're on a pressure control mode, but it is something that we absolutely do. If they do become agitated and start to desaturate, that is a sign that we need to give them more sedation to tolerate that ventilator setting better. And so first we'll try switching to, or I'm sorry, administering sedation and seeing if that works for us. It seems because it's saying they become agitated and desaturate, this is an agitation problem. Agitation and vent desynchrony cause desaturations for two different reasons. When we are agitated, we're obviously, our oxygen demand goes up. So that can cause us to desat. On the other hand, if we have that vent desynchrony and we're not allowing, the patient's not allowing for the breath to be given to them, that amount of pressure, then they are not receiving the full benefit of that ventilator, and that can lead to desaturation. So sedation can help us in both of those areas, lower the oxygen demand, and then help with the allowing the ventilator actually deliver the breaths as it is needed. So the answer here is going to be B, sedation. If that doesn't work, we find that the patient's still desatting, maybe then we're thinking, do we need to switch around the ventilator mode? But if there's a symptom going on with the patient behaviorally, that's typically our problem. And then we will control that variable and move on to the next one. Okay, good job, everyone. Let's try this one. A patient with type 2 diabetes presents with altered mental status. Glucose is 720, pH is 7.38, and bicarb is 22. Which initial intervention is most critical? What do we think for this one? I have a feeling we'll probably know this one. If it's your first time here, just a quick, not really a warning, but just an FYI, I do pick slightly more difficult questions for these webinars. They're not always crazy difficult, but I don't want to spend a ton of time talking about things that most people might feel really confident about, just because we want to use this time wisely. And we've got the time to have a verbal rationale. So if you feel like you're struggling with the questions, don't feel like all CCRN questions are as difficult as the ones I choose for this. Okay, I've gotten quite a few different answers, which is always kind of fun. That tells me that we've got things to talk about, and that's a good thing. That is a good thing. So I think I've gotten every single answer, A, B, C, and D. The answer here is going to be B. With this, well, first of all, we've got type 2 diabetes here, altered mental status, glucose is high, pH bicarb. What does this person consider? What am I thinking of? What is this person experiencing? What condition do they have? Yeah, Sonia, you're right. Yeah, we're concerned for HHS or HHNS, right? Absolutely. We know that this isn't DKA because our pH is normal and our bicarb is relatively normal. So this is HHS. With HHNS or even sometimes DKA, our main priority is going to be fluid resuscitation, especially with HHNS, because of that hyperosmolar tension that's going on within the bloodstream. This person is extremely dehydrated, and that is actually more dangerous than the high glucose itself. We need to give them some fluid. So our first priority is going to be fluid replacement. Then we'll start thinking about administering some IV insulin, usually in the form of a bolus dose first, followed by a continuous infusion. So multiple factors told us that this was HHNS. Type 2 diabetes being one. Lots of things put us there. First line, we know this person's super dehydrated. Give them some fluid. Then we can think about IV insulin. We don't necessarily need to obtain urine ketones. We don't expect that this person's in DKA given their other labs. But if we wanted to fully confirm that, we could send off some urine ketones, but it's not going to be our initial intervention. And then administering potassium replacement. Is this person's potassium high or low, do we think, right now, before we've started any insulin, given any fluids? What do we think their potassium looks like? Do we think their potassium is high, low, or normal? Yeah, their potassium is likely high, you guys. It could also be normal, absolutely, but it's probably not low. And the reason for that is this person does not have enough insulin floating around in their bloodstream. They have a little bit because they're type 2 diabetics and not type 1, but they don't have enough insulin. And insulin does two things. It carries glucose out of the serum space and into the cell, and it carries potassium out of the serum space and into the cell. So when we don't have enough insulin and that glucose is hiking up, our blood glucose, so is our potassium. So likely a lot of these patients come in and they are hyperkalemic. That's a lot of times we see that with DKA as well because we've got that acidosis component, and acidosis and hyperkalemia are kind of friends with each other. So we definitely see it in DKA. We can also see it in HHNS. And when we start this insulin infusion, we're wanting to think about what's happening to that potassium. It's likely normal or high. Are we dropping it too fast? That's when we would maybe think about administering a potassium replacement, but it's not going to be our initial intervention because we haven't started any insulin yet. And that potassium is likely high. Okay, any questions there? How do we feel about that one? If not, I will just move on to the next. All right, question 3 here. A patient post-trauma has bleeding from IV sites, low platelets, prolonged prothrombin time, and elevated D-dimer. What is the best nursing action? And I'll just be honest, this is not my favorite question, and I'll explain why as well. But what do we think? Good job, Cecilia. Good job, Sonia. Yep, you're on the right track there, James. Perfect. Okay, so our answer here is going to be B. We're going to transfuse fresh frozen plasma. And I'll tell you why I don't like this question. I don't like when the answer choice is telling us to do something when we don't really have hard evidence. When we were given the stem of this question, we've got bleeding from IV sites, low platelets, prolonged PT, and elevated D-dimer, but we don't have any numbers, which makes it harder for me to justify administering a blood product. But you could absolutely still run into a question like this where you need to use the information that you've been given and still come to a conclusion. And out of all of the answer choices here, administering fresh frozen plasma is absolutely our best choice. Let's walk through some of these others. Well, first of all, before we even get there, what condition do we think this person's experiencing? They're post-trauma. It's a coagulopathy. It's not HIT. Good guess, though. Not ITP. I know that we've got this low platelets, and that can kind of get us into that thrombocytopenia range. Yep, somebody here on Facebook or YouTube's got it. YouTube. Yeah, there we go. And McKinsey. Awesome. Yes, this is DIC. Post-trauma, DIC is a condition that has to be triggered by something else. It can't just spontaneously occur by itself. Trauma, sepsis, obstetric complications are great common triggers for this. We've got bleeding from IV sites, low platelets, prolonged prothrombin time, elevated D-dimer, meaning we've got lots of clots happening, and now we need clots in some places, and we don't have any clotting factors left. We've run out of platelets, we've run out of clotting factors, which is giving us our prolonged bleeding time, and we've got a heavy clot burden, and that's evidenced by our D-dimer, which is a clot degradation product. Okay, so if we look at this panel and we're thinking DIC, which is a coagulopathy, we need to give some clotting factors back to this patient, and we can do that in the form of fresh frozen plasma. It's chock full of clotting factors. We're not going to initiate heparin because they're oozing from bleeding sites. We're not going to administer vitamin K, even though that PT is prolonged. We've heard nothing about warfarin. We would only ever give vitamin K if it's a warfarin-caused prolonged PT-INR. And withhold invasive procedures is absolutely a great thing to do if we can. They're post-trauma, so they might need some surgery. I'm not sure. But our best thing to do to fix this panel here, this coagulopathy panel, is give that fresh frozen plasma. Okay, Awesome job, everyone. Let's keep trucking along. Like I said, I know that these can be a little bit tricky. All right, this is our hemodynamics question. I always try to put at least one of these in here, and this one's a little bit longer, so I'll give you a little bit more time. A 68-year-old patient with a history of ischemic cardiomyopathy, where their EF is 20%, presents with confusion, hypotension, their MAP is 55, cool extremities, and jugular venous distension. Their PA catheter readings show a CVP of 14, a pulmonary artery pressure of 40 over 22, a pulmonary artery occlusion pressure or a wedge pressure of 22, and a cardiac index of 1.5. What is the most appropriate first line intervention? Lots of things to consider with this one. Good job, William. Moonjan, Ariel. Yeah, I hear you, Cecilia. Good job, James. All right, let's go ahead and talk about it. We've got two main answer choices coming up, and they're absolutely the top two. So good job for narrowing it down to those two. So the top two answer choices I'm seeing are B, administer IV furosemide, and C, initiate a dobutamine infusion. So let's keep those in mind and let's look at this question. Let's dive a little bit deeper into all these words we got up here. So we're dealing with ischemic cardiomyopathy where our EF is 20%. So we have a poorly functioning, this would also be um, a systolic heart failure where the problem is our systole, our ejection fraction is poor. So our EF is 20%, and we're getting all these symptoms from it. Our MAP is low, our MAP is 55. Extremities are cool. We've got jugular venous distension, and all of our hemodynamics are telling us that that heart with that EF of 20% is not doing a good job of establishing forward flow. We can see that because our venous pressure, which is a volume indicator, is high at 14. Our pulmonary artery pressure is high at 40 over 22. Can anyone tell me what a normal pulmonary artery pressure is? What do we normally want our pulmonary artery pressure to be? Or what's like yeah, 20s over teens or quarters over dimes, right? So this is high. CVP is also high. We like that more around 2 to 8, but it's a highly variable number. So I like to have it paired with some other numbers. PAOP, our wedge pressure, telling us how much volume is sitting in that left atrium. It's giving us a picture of the left side of the heart. That is high at 22. We usually like that below 15 or so. And our cardiac index is 1.5. That's really, really bad. And that's an index. So it's taking into consideration their surface area, their body surface area, and it's really low. So I can totally see why we would narrow this down to, well, this person's fluid overloaded and their heart can't handle all of that volume. We've got to give some furosemide, right? Or their heart is not functioning well. It's EF of 20%. Our cardiac index is horrible. Let's give some extra inotropy to help that heart out. So the answer here is going to be C. We're first going to help the heart out by giving it that inotropic support to help move some blood forward, give it back that forward flow. The reason is because we need to get this map a little bit higher before we can afford to take volume off of the bloodstream. We do not have pressure to give. And so furosemide right now is going to be a little bit dangerous. What we might do is start this dobutamine infusion, see if we can increase our cardiac index with that, get that heart to pump a little bit better, give us a little bit more blood pressure because our cardiac output is increased, and then we can tackle the fluid overload issue. The problem is that even though these numbers here, the CVP, pulmonary artery pressure, and wedge pressure, are painting a fluid overload picture for us, the patient might not necessarily be overloaded. Their heart just can't handle the volume that is on board. So if we can give inotropic support, we might be able to avoid giving furosemide if that's all that's needed. That's something that we would reassess after starting that inotropic support. So the answer here, like I said, is C, initiate that dobutamine infusion. How do we feel about that? Does that make sense for everyone? All right, perfect. Let's move on. Awesome. Thanks, guys. Let's move on to this one here. Another ventilator question. A ventilated patient post-esophagectomy suddenly develops decreased breath sounds on the right, subcutaneous emphysema, and hypotension. Ventilator is showing high peak pressures. Which intervention should be performed immediately? Again, think through what condition you think the person's experiencing and then choose your intervention. Great job. If you've answered so far, you're right. Okay, before we say the right answer, what condition do we think this person's experiencing? Good job. Yeah. Pneumothorax, right? This is classic pneumothorax. The only thing missing from it that would really put us in that tension pneumothorax category, which this person's probably having a tension pneumothorax as well. But we're not seeing tracheal deviation just yet. So it's not as severe. Maybe that symptom's just not being listed. So this is classic pneumothorax, with especially with that subcutaneous emphysema, reduced breath sounds, hypotension, high peak pressures. These are all things that paint that picture for us. The best thing to do is prepare for that emergent needle decompression. In practice, we'd probably be preparing for an emergent needle decompression and getting a stat chest x-ray as well. What really disqualified A from being the answer is this is not a bronchoconstriction problem that an albuterol inhaler is going or nebulizer is going to help with. So we're not going to do A. We're definitely not going to increase PEEP and FiO2 when we're having high peak pressures like that. And placing the patient in Trendelenburg position is not going to help anything either. Okay, so awesome. Way to go, everyone. Let's keep moving. I think everyone got that one correct, so that's awesome. Um, yeah, we've got plenty of time. A patient with acute pancreatitis reports increasing abdominal pain and dyspnea. Vitals are heart rate of 132, respiratory rate of 32, PaO2 of 60 on 6 liters nasal cannula. Physical exam reveals decreased breath sounds and abdominal distension. Which test will most likely confirm the suspected complication? So again, think through what you think is going on. What complication are you concerned for? And then what test would you do to confirm that suspicion? What do we think? And you can throw any of that in the chat. What condition you think this person's experiencing, and then what we would do to confirm that. Okay, so let's start there. I've got some answer choices in. What condition, if we've got acute pancreatitis, now we've got some abdominal pain and dyspnea, and this is our look here. We've got really high respiratory rate, pretty poor PaO2 to be on 6 liters nasal cannula. What condition are we concerned about here? We know we've got pancreatitis, which is probably leading to that abdominal pain and abdominal distension. The condition that we're concerned for is ARDS. Acute pancreatitis is a massive risk factor for ARDS because of the inflammation response that follows pancreatitis. Pancreatitis causes a huge inflammatory response, and that is going to cause that vasodilation and increased capillary permeability to happen everywhere, including our alveolar membrane. So if we're concerned for ARDS, what do we think the answer is? You're right, Sonia. Which one of these tests is going to confirm that suspicion? It's not going to be C. C is going to tell us a little bit more about what's going on in the abdomen. If we're talking about ARDS, we want D. Yes, we want that chest X-ray. We don't need a CT of the chest with contrast because we're not as worried. What would be the condition that would kind of match with that? With this, we've got some respiratory concerns. What condition would we get a CT of the chest with contrast with respiratory concerns? Yeah, exactly, Cecilia, a PE. And as much as, I mean, of course, anybody can get a PE at any time. Pancreatitis with this exact vital sign panel is likely telling us that they're in ARDS because, like I said, pancreatitis and ARDS can go really close together. PE is a little bit less common, not to say that it can't happen. It definitely can. But that CT of chest with contrast, that would be if we were concerned about a PE, not totally what we're thinking. Serum lipase and amylase, somebody already said it. We've already confirmed they've got pancreatitis. We're talking about the complication from their pancreatitis here. Abdominal ultrasound, same with our thought process about that pancreatitis. We've already confirmed that. We might want to take a closer look at that abdominal distension potentially, but we're likely not going to need that abdominal ultrasound. We're trying to confirm a suspected complication, that being ARDS. That's going to be a chest x-ray. Okay, good job, everyone. Again, I know these are multi-layered questions, and I like them for that. I like that it causes you to have to first think about what the complication is and then pick an intervention or then pick a diagnostic. It makes it a layered question, which is nice. Um, but but yeah, and that is a tough one. The other thing I'll say too is really hinging on what information you're getting in the question. So a lot of our symptoms are related to the respiratory system. We got dyspnea, we got an increased respiratory rate, heart rate can relate to our oxygenation status. PaO2 is falling on max nasal cannula, obviously not high flow, but for simple nasal cannula. Decreased breath sounds, abdominal distension, telling us that there's that increased capillary permeability from that inflammation happening everywhere. We were given so many points pointing to the respiratory status, and then just walk yourself through, well, what complication can occur respiratory wise from pancreatitis? And the most common one will be ARDS. Alrighty. Let's do one last one and then I'll let you go. A patient with hepatic failure has altered mental status, elevated ammonia, and asterixis. Which intervention is most appropriate? Gosh, I feel like I've maybe done this question before. So if you've been on one before, you might recognize it. Problem to find what the question is asking. Any tips? Yeah, absolutely. We'll get through this question and then I'll answer that for sure. Awesome. I feel like everyone's pretty confident in this. What complication or condition are we concerned for now? That's guiding our answer choice. What would we call this condition? Hepatic encephalopathy. Yes, absolutely. So we've got that altered mental status. That's encephalopathy, classic. Asterixis is as well. Elevated ammonia tells us this is a hepatic problem, in addition to the fact that the question told us this was hepatic failure. That elevated ammonia is toxic. That's what's going to lead to those encephalopathic symptoms. So once you determined this is an encephalopathy issue due to that elevated ammonia, our primary treatment for that is going to be lactulose so that we can bind that ammonia in the GI tract and get it to be excreted that way. These others we are not going to be concerned with. We just want to lower the ammonia, and the best way to do that is lactulose. So really quickly, let me pop back up and answer this question. If you're trying to see exactly what the question is asking, obviously the first place to start is at the end. And sometimes I recommend that people read the end of the question first. I don't recommend this for everyone. If you find it to be distracting for you, then don't do it. But you can give it a shot. Read that question, the true stem of the question. So, what intervention is most appropriate? Maybe before you read the rest of the question, you jump there first to understand this is going to be the point of the question. Because a lot of these CCRN questions can get really long. I mean, we think about that one that had the hemodynamic profile in it. Which one was it? This one here. That you're given so much information, and then you're supposed to come to some conclusion about it at the end. And that can be a difficult thing for sure. So if you take a question like this one, this really wordy one, and you read the true question first, what is the most appropriate first line intervention? You can already start to kind of guide your brain to interventions because questions are going to ask lots of different questions. They're going to ask, what condition do you think this person's experiencing? What's the best thing to say to the patient if we're dealing with professional ethics questions? What diagnostic tool would you recommend? Or what's the first line intervention or what are we doing next? Read that first and then tackle the question. And the other thing I say too is to really look at what the question's focusing on. Like that one question where it was a lot of respiratory stuff, even though it said we've got acute pancreatitis, it was giving us a lot of respiratory information. So focus in on the info it's giving you and try to let that kind of tell you what's going on. You shouldn't have to look into the questions too much, but you might have to kind of analyze just the frequency of what type of information is it giving me. And then let that kind of guide you. And a lot of times these questions all really had a very similar theme of it wanted you to understand what condition the person was experiencing first. And it's not even asking you that question. It's just going to base the actual question off of that understanding. So try to establish that first. As you read through these questions, really start to orient yourself. With a question like this, you're like, okay, we've got an EF of 20%. The heart sucks. It's not doing a good job. We've got evidence of poor perfusion, and kind of walk yourself through and start to summarize in your own head what all of these various data points actually mean. Paint a picture for your patient and then tackle the answer choices. That's one of my biggest tips is to not look at any answer choices until you have summarized the patient's condition in your head. You've worked through and said, well, I'm seeing signs of poor perfusion. I'm seeing signs of a dysfunctioning heart because my EF is 20% and my cardiac index is 2.1. We've got a backup of blood flow and my perfusion is low. Now let me think about what my most appropriate first line intervention is. I'm going to answer that in my head first, and I'm going to see if an answer choice matches what I think I would do in that moment. Does that help? That little walkthrough. Any other questions related to that? A lot of it comes down to that. You can feel really confident in the material itself, and then you get in front of a question and it's a totally different experience, regardless of what you feel like you know. So really just try to orient yourself to what you do know, especially before looking at any answer choices. That's my biggest tip. Yes, overthinking is a big thing. Absolutely. So yeah, that would be my advice to you or anybody who's struggling with overthinking. Take those data points that you're getting from the question, paint a picture for yourself of what you think that patient's experiencing, and then read the answer choices. Don't let the answer choices guide your thinking too much. Kind of establish with yourself, you're a confident ICU nurse. The CCRN is different in that way than the NCLEX. It's testing for a confident ICU nurse, not a new grad nurse. So think confidently, put your thoughts together, and then look at those answer choices. Okay, our next webinar isn't for 2 weeks. I am out of town at an anesthesia conference next week, and so I can't do a webinar, but we will be right back the week after. And there's the link to sign up for our next one. And then here's the link just to go to our landing page, just to see the site, in case you haven't seen exactly what we offer as far as courses and everything. And QBank, you can take a look there. But thank you so much for everything, everyone. Thanks for being interactive. That was a fun one, and I will see you 2 weeks from today. Bye, everybody.